I'm Dr. Rob Myers, and this is Cardio Talks. I'm a cardiologist at Sunnybrook Hospital in Toronto, and the goal of these videos is to explain common cardiac conditions in an understandable manner. We've talked about atrial fibrillation in a series of multiple videos, and this specific video is going to be about the heart rhythm control strategy. Now, atrial fibrillation, by its definition, unfortunately, is an annoying, difficult to treat rhythm. It is something that requires an empiric approach. So 10 patients can get 10 completely different management strategies, which is why your friend or neighbor or relative's experience isn't really important for you. It's much more important to think of it as an individual experience. Rate control, which I've talked about before, and rhythm control are completely different. Heart rate control means I'm going to leave you in the rhythm and make sure your heart rate isn't too fast and you feel well. Heart rhythm control means we're going to try to control the rhythm. Often younger people have more symptoms and control of the rhythm is more important for them. So once we've made a decision to try to control your heart rhythm, typically because your quality of life is impacted and it keeps coming back, what is available? I've talked about a step approach, which is like a staircase. So you start with this and you go one step at a time. So what is the first step? So you come to see me. You've had an episode of atrial fibrillation. You've been sent home from the emergency department. And you've come to see me and you're no longer in it. Now you could still be in it, but let's say you're no longer in it. What am I going to do? If you had symptoms and it's your first episode or it's very infrequent, well, the first step is called a pill in the pocket approach. It's exactly that. I'll give you a drug. I'll give you a prescription for an anti-arrhythmic. An anti-arrhythmic drug is exactly that. It combats rhythms. Problem is it's only moderately effective. So the goal in giving you this drug is to reduce frequency. If it takes it away completely, you're lucky, but typically it will not do that. As I've spoken about before, it's like a goaltender. You're going to let in a few pucks. We want to let in as few as possible. So the drug, there's lots of choices. It can be sotalol, it can be flecainide called Tambicor, it can be propafenone. So you've got this pill bottle. And you have symptoms, and you know what they are. It's really important, because if you don't know you're in atrial fibrillation, then a pill in the pocket is useless. But it gives people a little bit of confidence, right? You're on an airplane, you're hiking, atrial fibrillation happens. Nobody wants to go to an emergency department in another country, that's for sure, let alone your own country. So you take the pill. So people say, well, when do I take it? Well, you take it when you have symptoms. Now, you can wait a few minutes because sometimes these things go away on their own, for sure. If you're severely symptomatic, you go to the emergency department, obviously. Let's say you're sitting around doing what you're doing and you're like, yeah, I'm in atrial fibrillation. Some people can check their pulse. I'd like to explain to patients how to do that so that they can see if it's irregular. But in this case, let's just assume you have symptoms. And whether it's a rapid heartbeat with or without lightheadedness or breathless, the key is you've had it before, you know what it is. You take the pill. So it's going to take, 10, 15 minutes for it to be absorbed a little bit, and then maybe another 10 or 15 minutes to act. But what the pill does is it can convert the heart rhythm into a normal rhythm. Now, it's only going to work about half the time. But if you have 3 episodes a year or 4 episodes and you end up in the emergency department twice a year instead of 4 times a year or once a year, I think that's a pretty good solution here, and it helps you a lot. So that is called a pill in the pocket approach. What if it no longer works? You call me up and you're like, hey, Myers, I tried the pill in the pocket, but I'm still in the emerge every month. I'm getting 3 episodes a month. It's increasingly frequent. What is the boundary? Well, it's your boundary. It's where you decide that your quality of life is sufficiently impacted that we need to move to the next step. And the next step is a drug like that, the anti-arrhythmic, to take every day preventatively, no longer reactively. Because remember, atrial fibrillation is a dynamic rhythm problem. It's just not static. The management always changes. Usually changes. And so the next step is, all right, maybe I'll give you sotalol, which is also a beta blocker, so it can be fatiguing and therefore won't work for some people. I may not use it if your baseline heart rate is already slow because it's going to make it slower. I'll use that drug, or I'll use a drug like propafenone or flecainide. Now, if you use propafenone or flecainide, theoretically, if you have atrial fibrillation on that drug, the speed of your heart can really go faster. So those drugs are used with a drug that slows down the heartbeat separately, which to me is a pain in the butt, right? So now I'm giving you 2 medications, let alone you want 1. Now I'm giving you 2, but it is what it is, right? I don't make these things. So those are options for treatment. Now, if that doesn't work, so I give you the drug, I usually will give a smaller dose. And I'll also pay careful attention to providing you a list of the symptoms that can arise, the common ones. You know, if somebody's toenail turns purple during a study, they'll list that as a side effect. So you want to look at common side effects. You don't want to look at the less than 0.01% side effects, because you'll find anything. So I'll give you a lower dose. Now, the problem with a lower dose is the lower the dose, the less effective it is. But the higher the dose, the greater the risk. So we have to find some kind of a sweet spot. I'll check your kidney, I'll check your liver in terms of blood tests. And I'll also, after I put you on these drugs, you have to get an electrocardiogram or ECG, because that'll make sure that there's no potential toxic impact that maybe we're not aware of that can show up on the EKG. So I'll try a lower dose. Now, if you come back to see me and you're like, it's not working, I might give you a higher dose. I might switch you to another medication. Now we're on the 3rd step. So that's the problem, is these drugs are really effective as a percentage in the same way. You know, your chance of another episode within 18 months is probably 50%. There's one drug called amiodarone, AMIO. It is the most effective drug. Problem is it has the potential for side effects. That's scary. These are scary side effects. And now they are dose dependent. So at very high dosages, over 3 or 4 years, you might have a 1% chance of fatal lung disease. No wonder nobody wants to go on the drug. But 1% with a very high dose. And with atrial fibrillation, with amiodarone, we use lower dosages. Really important to think of amiodarone as something, it can cause liver, lung, and thyroid. It can also make your skin sensitive to light, can cause a little tremor, can make your writing very small. So it does these things. Now, if we only looked at side effects, you'd never take a drug. If I told you the potential complications of flying in an airplane, you'd never fly. So it's always frequency. But I wouldn't want to use it at a young age. And so we tend to use amiodarone typically in older people because they have a shorter lifespan in terms of developing side effects. Or we'll use it in people whose underlying heart condition is really severe. Heart failure, all sorts of issues. And controlling the rhythm is really important. Like more important than I have an occasional palpitation. More like when I have it, I rush to hospital with heart failure. So there are people that we will selectively use amiodarone in. And then you'll need your liver tested with a blood test, your thyroid tested, and a lung function test every year. So if those drugs don't work and you still are plagued by symptoms, then we'll consider an ablation strategy. I don't like ablation. Now, I don't do them. I'm okay to be criticized by people that do them and say, stay in your lane. I get that. I want people to stay in their lane. But statistically, an ablation is going to have a higher risk of complications than you're going to be comfortable with. That's why it's at the top of the pyramid, and that's why I send less than 1 in 500 people for it. So what is it? You go into the heart through the blood vessel of your leg. So we snake a catheter into your heart. We means electrophysiology doctors, special cardiac electricians. And interestingly, you don't really feel that. It's like being at the dentist chair. You get freezing in the inside of the blood vessel and heart don't feel anything. And you're lying down like you're in an operating room, but it's not an operation. And then the electrophysiologist basically creates these linear burns or scars inside the heart where the electrical impulses start and propagate or continue. It's a pulmonary vein ablation. What's the problem? About 1 to 2% chance of harming you irreversibly. Not just death, but strokes, blood clots, poking a hole in your heart, causing septic emboli. So all sorts of septic embolus means you have an infection that's in your brain. Lovely. So all comers, 1 to 2%. It depends who you're seeing, right? But that's really high. I don't want the cure to be worse than the disease. And it's not a full cure. So in maybe 65 to 70% of people, they'll be free of atrial fibrillation for a year. Well, I don't think that's worth it. Who is it worth it on? Well, it's worth it in selective circumstances, right? If you've got a lot of symptoms and nothing else helps, get the ablation. But I don't want anybody poking around in my heart unless I really need it. So it's by guidelines, it's not supposed to be offered first. It often is, and it's touted as a cure. And I find it a little bit of advertising and marketing, but dead men tell no tales. So I'm not trying to freak you out and make you totally fearful of it. It has its role. Just make sure you're seeing a very good electrophysiologist who will give you a balanced view. I once had an electrophysiologist tell me to stop scaring his patients. So that is the approach to atrial fibrillation when it comes to a rhythm control strategy. The bottom line is it's tough to fix, and we are often unsuccessful and leave people with either chronic atrial fibrillation, the best we can do, or frequent episodes. I hope that helps.